Okay. Thank you, Brianna.
Okay.
All right. So where was I? Before fluid enters the kidneys, it's blood, right? What did he say? About 25%. So we have blood that leaves the left ventricle and goes up to the aorta, right? Left ventricle to the aorta, aortic arch, and then it goes down. So from here, there's some vessels that branch out and go up to the head. Okay, and then as we go down, there's some vessels that branch out and go to the upper extremities. And then as we go down further, there's a vessel that goes to the liver, right? And then we have one that goes to the kidneys, or two for each kidney. And then it continues going down into the, oh my gosh, what is it called below the abdominal aorta, and then into the femoral veins into the extremities. Okay, so we have that basic circulatory pattern, and then we have where it branches off to the kidneys into the liver. Okay, so we go from the vascular system to the kidneys. Okay, we filter out the filtrate, what's going to be urine, and then depending on the composition of what's going on in our cells and our tissues, we'll either excrete a little more sodium or keep a little more sodium or potassium, whatever it may be. Okay, and then from the kidneys, the ureters they have peristaltic waves, that muscular waves that move that urine down and prevent backflow going back into the kidneys. Okay, so there's an opportunity for obstruction in the kidneys themselves from things like tumor, or we talked about if your body is breaking down the calcium from your bones, pulling it out of your bones into your blood, you might see it in the urine, and you can develop a kidney stone, which can cause a blockage. Okay, so those things can happen in the kidneys themselves or anywhere in the ureters. Okay, and then down into the bladder is the collecting organ of urine. So once it's down in the bladder, it should never come back up into the ureters, because that can cause infection, and should go to the bathroom really like every 2 hours. Is a good frequency to empty that bladder. And then as the bladder fills, you know, it's a hollow muscle, it fills, and you can feel that pressure. There's hormones involved that tell you that it's time to release that fluid. And as you talked about in the video, you have an internal sphincter that is technically involuntary, and then the external is voluntary. Okay, and that's the same thing for feces as well, which we'll talk about next week. Okay, you can see the female urethra is all internal, and the male urethra has some external component to it. Kidneys, this is just giving you an idea anatomically about where the kidneys are located. Okay, down by the lumbar vertebrae. You can see it's the renal veins and arteries that carry blood to and from the kidneys. On top of either kidney are the adrenal glands, which are, they secrete hormones. They're involved with your endocrine system, okay, which is probably the most difficult body system to understand, I think, is the endocrine. So, and in second year, you'll go through. So this year, we have our schedule that we have in this course, and then next semester, it's very much, it's repetitive, but more involved, more in depth, and then more specifically to surgical patients. And then you also will talk about diabetes, and then you'll do some OB next semester. Okay, and then third nursing course, you'll have some pediatrics, and then you start by body system. Okay, so you've had all this overview stuff, and then you're gonna go through each body system. So problems with the circulatory system, problems with the respiratory system, problems with the endocrine system, and on from there, GI. Okay, so you'll have this content, again, really, but focus on disorders. Okay, that's third semester, and then by fourth semester, you pretty much are finished up with all the body systems, and you do any that are not left, and then you do a stroke in service, like what they're doing right now. They get stroke certified, and then the rest of it you focus on ACLS. So you'll be ACLS certified by the end. So you'll run through, like every week you do practice codes and mega codes, and then before you graduate you'll run a code. So that is pretty much the gist of it.
Do you want to teach us the rest of the course?
That's what everybody says. Yeah, you're gonna miss me next semester, guys. You don't know how good you got it. Here's a cross section of a real live kidney, with the arteries and the veins. Okay, it's super involved. The nephron is the basic unit, right, with those tubules. You don't have to remember all those different tubules. It's good to watch it and to think about it because it makes sense of how it controls blood pressure and fluid volume and electrolytes. Okay, the bladder, we talked about this stuff here. Okay, urethras, we talked about. Okay, the active urination at about 150 to 250 milliliters is when you'll start to feel that sensation of void. Okay, stagnant urine, so urine that's just sitting, is a medium for bacterial growth. Okay, so it shouldn't be in there for too long until it's excreted out of the body. Okay, every 3 to 4 hours, this says, to avoid urinary tract infection and kidney disorders. Okay, factors that affect urination. Aging, of course, is the main one. So remember that day that we talked about aging and how basically all of our body functions decline over time. We'll have the diminished ability of kidneys to concentrate urine. Okay, so just not as well able to control blood pressure and osmolality because of our inability to concentrate as well as we should. Okay, decreased tone and contractility, okay, especially women who have had babies. Okay, that those muscles down there get stretched out and weakened. Okay, so that can lead to stress incontinence. And then just physically, whether it be osteoarthritis or a cardiac or respiratory condition, any kind of conditions that will limit your mobility and ability to get up physically and get to the toilet can affect urination. Okay, psychologically, we talked about anxiety and stress, how really that can go either way. Typically when we're stressed and anxious, we have to pee a lot, or sometimes like patients are in the hospital and if like people are around and you have to pee, maybe you can't pee because somebody's in the room. But mostly anxiety and stress will increase urination. Okay, muscle tone goes along with the aging, the weakness of the pelvic muscles that we talked about. Exercise, so if your patient is active and exercises, the rest of their body, that should correlate with urinary control as well too. Catheters, if your patient has a Foley catheter, so a tube inserted into the urethra, for whatever reason, surgery maybe, or maybe they're critically sick and they are immobile for a short time. Once that comes out, they could have some period of dribbling and weakness for a while until that muscle gains its strength again. Okay, and then childbearing, we talked about, is the main reason for us women. After we push out those babies, we can have trouble. I remember after I had my daughter, who's 12 now, and I used to jog a lot, and so I went and I was jogging, and this woman I worked with was like, "Aren't you afraid that your uterus is gonna fall out?" And I'm like, "What?" I'm like, "No." But now, like 15 years later, I'm like, "Oh." Now I see what she means. My uterus is not falling out, but I'm okay, but I can see the potential there. Pathology or illness, if anything, if you're born with some type of congenital malformation of any structure in your urinary system, that could affect urination. Polycystic kidney disease is PKU, and it is just what it sounds like. Poly means many, cystic is cyst, and disease. So there's cysts that grow on the kidneys, okay? So it's not usable or productive or viable tissue, it's just there blocking the tissue from doing what it's supposed to be doing, so it can cause urinary retention or pain or difficulty. Okay, calculi are stones, which we talked about. Hypertension is going to blast through those capillaries. Remember how it showed you that capillary filtration directs the blood into that glomerulus so it can be filtered out. Okay, so if pressure is too high, it's going to blast through and damage that delicate tissue, and then it can't absorb and secrete as well as it's supposed to. Okay, diabetes is just going to accelerate that process, accelerate the aging process. It's usually correlated with hypertension. It's just going to wreak havoc. That glucose in the cardiovascular system is going to show up in the urinary system, and it's just that glucose isn't supposed to be there, so it's going to contribute to disease. AKI is acute kidney injury. Okay, so that could be from like if somebody is suddenly very dehydrated from maybe they ran a marathon and they didn't hydrate correctly, they can go into acute kidney injury where their BUN and creatinine are elevated and their hemoglobin's elevated and they've got all the signs and symptoms of dehydration and their kidneys just basically shut down. So we have to flush them with fluids, make sure that they're urinating. They might need dialysis, so one-time dialysis type thing. Okay, chronic kidney disease can lead to end-stage renal disease. Okay, so end-stage renal disease, that's the patients who are on dialysis. Okay, their kidney disease has progressed so bad that it just cannot function, it cannot clear out the waste, so those waste products are building up in your blood, which will cause you to become acidic, and then septic, and you'll die. If you don't get all that, you'll have a heart attack maybe, because your electrolytes will be all crazy. Okay, so they need dialysis. Chronic kidney disease develops through stages. I can't remember, I think maybe there's 4 stages, but it goes from early to late. Okay, so depending on when you catch it, how often your patient gets regular physical exams and follow-ups, it can be caught early or later. And once you have chronic kidney disease, you always have chronic kidney disease. So 99% sure you'll have a patient with CKD in clinical. Okay, medications. Remember when we went through medications, we talked about that some can be hepatotoxic, which is toxic to the liver, or nephrotoxic, which is toxic to the kidneys. Okay, so just some medications, just have to watch out for that. Diuretics are going to cause a patient to urinate more, right? And then they could have electrolyte imbalances. Okay, potassium is the main electrolyte imbalance that we're worried about. Because there's less leeway than there is with sodium, and there's more extreme side effects, namely your heart stopping from an arrhythmia. Okay, sedatives, of course, can lead to incontinence. Can also maybe lead to retention as well. It's kind of slowing everything down. Okay, anticoagulants will change your urine. What color maybe?
Pink.
Pink, maybe, from hematuria, blood in the urine. That would not be good. Okay, that if we look at their lab work, their platelets are probably low or their bleeding time is probably too high. They need to have their medication adjusted. Okay, and then food and drink. Sodium is going to cause us to retain fluid, and then eventually we're going to have to excrete that fluid as well. Alcohol and then caffeine both inhibit that antidiuretic hormone. Okay, labs, so the BUN, the blood urea nitrogen, measures the nitrogen fraction of urea. Okay, so urea,
Yeah,
I skipped something? Oh, you guys don't have this? I added this. You have this, and it's in your fluid and electrolytes slides. So you have it in there, I just copied it over and pulled it over here. So you guys can copy it if you want, or you can go find it in your other slide and copy it and paste it here. But you do have it, but I added it last night. Okay, so urea is a waste product, specifically from protein, right? And so of urea, part of it is nitrogen, okay, which is also a waste product from protein. So this measures the part of urea that is nitrogen. Okay, basically, it reflects protein intake and renal excretory capacity. Okay, so if there is kidney disease, we would most likely see an elevated BUN. Okay, 8 to 20 is normal. Okay, if they're malnourished, if they don't get enough protein to begin with to break down, their BUN could be abnormally low. Okay, and then if they're overhydrated, it could be abnormally low from dehydration, or from overhydration. So it's more dilute. If the BUN is elevated over 20, that's kidney disease. 8 to 20. Okay, and then creatinine, same thing, it's on your fluid and electrolytes, but I pulled it over last night. Okay, creatinine is always in the urine. Okay, 0.6 to 1.1 is normal for a woman. Okay, by the time that the creatinine is abnormally elevated, there's already 50%, at least 50% nephron damage. Okay, so BUN can be a temporary thing. The creatinine is more typically indicative of long-term permanent kidney damage. Okay, here is a picture of a urinalysis, the components that we look for. Okay, so urinalysis is different from a urine culture because a urine culture has to be sterile, right? We can't have any contaminants. We have to use sterile technique to obtain it. Okay, and once there's any urine in a Foley catheter collection bag, that bag is now contaminated. That bag's not sterile any longer, okay, because that urine's been sitting in it. So if we just immediately put a catheter in, we just put it in, and then we empty it from the drainage bag, sure, we could use that for a urine culture that first time, because everything is still sterile. Okay, but after that first time, that bag is just considered clean. Okay, it's not sterile anymore. So there's a port up by the insertion site that we'll use. Okay, so color should be straw, light to dark, depending on concentration, right? Depending on what we've been drinking. Okay, should be clear. Shouldn't see any sediment or pus or anything like that. Okay. Specific gravity you don't have to memorize, but it has a designated specific gravity. pH, okay, it's typically around 6, it's slightly acidic. Okay, glucose should be negative. There should not be glucose in the urine. Okay, that could be a sign of diabetes, right? Okay, ketones should also be negative. Okay, that means that your body is breaking down fat. Okay, it's more often seen with the type 1 diabetic that it would get to the point to break down fat. Okay, ketones is a breakdown of fat, should not be in urine. Blood as well, there shouldn't be any blood in the urine. Okay, we do have some protein, shouldn't be over 20. Okay, bilirubin should be negative. Okay, bilirubin, urobilinogen, those are like breakdown from red blood cells, and your liver is supposed to filter that stuff out, bilirubin out. So it should not be in the urine. Nitrates should be negative. That can indicate infection if there's nitrates, as well as leukocytes, which are white blood cells. Okay, should also be negative. Okay, main ones you want to focus on. If you look at those pictures, you can see the urine in the middle is most normal. That would have a normal specific gravity. The pH looks like it should be between 5 and 8. If you look at the one on the left, it would look like it would have a lower specific gravity, so less mass, more dilute, okay, overhydrated. And the one on the right is going to be more concentrated, so it would have a higher specific gravity, more particles in there. Okay, leukocytosis, elevated white blood cells, infection. You might see pyuria or pus in the urine. That can indicate a UTI, urinary tract infection. Okay, so if we have like a routine urinalysis, which a urinalysis is a pretty common diagnostic test for a patient admitted into the hospital, but a urine culture is not. urinalysis shows some leukocytes, then they'll spin it back, send it back for a culture, and then see specifically what is growing and what to treat it with. Okay, glucose in the urine is known as glycosuria. That can indicate diabetes. Erythrocytosis is hematuria, red blood cells in the urine. That can indicate some internal bleeding. Okay, and then proteins. If the protein is too high, that could be from working out too much catabolism and anabolism of muscles. Might see it in pregnancy, because we're building a new human. And then in hypertension and heart failure, because the damage is causing those proteins to leak through. They shouldn't be leaking through, but if there's damage from hypertension and heart failure, now they can leak through because of the damage caused. Okay, urodynastic studies. Urinalysis is just pee in a cup. Usually 10 milliliters is all that's needed. Okay, your facility will have a specific container. It might look like, where's my mouse? It might look like this. Oh, you can't see it up there. It might look like that little cup. Most of the time they have an orange lid on them, but it just depends on your facility, what they ordered, who had the cheapest supplies that week, whatever they stocked with. Okay, urodynamic studies. You don't really have to think too much about those. Those are highly specialized studies that are usually done in a specialist office, and they fill their bladder and hook them up to all kinds of measuring equipment to see how they urinate and how their GU system functions. A cystoscopy, we'll go ahead and watch that video. Sedation and analgesia is given, so that patient's going to need informed consent. Let's go ahead and watch that. Oh, you can't see.
demonstrate office cystoscopy right now. And we're going to show exactly what happens during office cystoscopy.
Can you guys hear
It's a
that?
very simple procedure that your physician may order for you. So we're going to get started now. She's already been numbed. My medical assistant is numbing jelly into the urethra. So should be minimal discomfort at all. Okay? I promise to do my best not to hurt you. Okay. So I'm just going to separate the labia here. Gently slip this in. A lot of jelly on there. Okay, the muscles are kind of tightening. Okay, we're past the sphincter. That's the worst part. And I'm going to look around. And we do have a monitor that patients can visualize the bladder on the monitor if they request to be able to see what I'm seeing. But otherwise, I get a much better, quicker view if I just look with my eye. So I'm looking around the bladder. There's water flowing in. So tell me if you start to feel too full. Okay. This only takes a couple of minutes. There's a bubble in the bladder. So after we're done, she's going to go to the bathroom and she might feel some bubbles coming out. Looking around. The left side of the bladder is looking fine. And the trigone, where the ureters, the kidneys are dumping the urine into the bladder, those look fine. And looking at the right side of the bladder, everything looks good. She has had a lot of infections like symptoms and burning. So we want to make sure there's not an ulcer, a tumor, or a stone in the bladder, any other abnormality. So we're done. I've triple checked everything. I know you're probably starting to feel like you need to go to the bathroom, and I'm just about done looking at the urethra. Water off. Okay, we're all done. That's all there is to it. Thanks.
So that tubing was like a bag of saline connected to the scope that was flushing through, and you'll see that the urinary doctors will do those at bedside in the hospital. So you might see that.
This unforgettable vacation memory.
I wish she would have shown the screen to see like what she was seeing.
Yeah. Let's see what my other one is. This one will give you some images, and it's going to be like the same. of
Do
what
men
she
get
was-
those done?
What?
Do men get those done too?
What?
The
Men?
size?
Yeah. Mhm. Yep.
They probably use the data.
Yeah, they probably freak out. It's like, us when we're with our pap smears and stuff, we're like, well, whatever. Just go over there. Men will be like, no, touch me.
I think this one shows like internally the anatomy.
Unless you watch my child first, if he saw like everything. What? That's a big deal. I didn't have to.
Maybe you've noticed that every time we talk about a new system, we highlight.
Tell your doctor about any recent illnesses or medical conditions, medications you're taking, and whether or not you have any allergies, especially to iodine-based contrast materials. Inform your doctor if there is any possibility you may be pregnant. You may be asked not to eat or drink anything and to take a mild laxative the evening before the exam. Leave any jewelry at home and wear loose clothing. You may be asked to wear a gown during the exam. You may have concerns about IVP. While an IVP exam does use radiation, the benefit of an accurate diagnosis far outweighs any risk. Plus, an IVP exam may provide enough information to allow your doctor to treat you with medication and avoid invasive surgical procedures. To learn more about intravenous pyelogram, visit radiologyinfo.org. Thank you for your time.
All right, so those are a couple examples of diagnostic tests that you might see beyond the urinalysis or the urine culture. A retrograde pyelogram is the same thing as an intravenous pyelogram, except for they'll inject dye in the urethra. Okay, so instead of just injecting it into the circulatory system and letting it find its way to the kidneys and work its way through, it's retrograde or backwards, so it starts at the end, at the urethra, and they inject the dye that way and follow it up into the bladder. Okay, and ultrasound, we can do that of the structures, and a CT scan as well. Okay, some equipment that you'll want to be familiar with is a urinal. You guys all know what a urinal is. I don't have one on this picture, but the little clear plastic device that has a handle on it, and it's angled so that they can use it in bed and hopefully not make a mess. And then there's measurements on the side as well so that you can document output before you empty it into the toilet. Okay, a bedpan. If your patient is bedbound, they might have to have some assistance with getting on a bedpan. There's generally two types of bedpans, like the big one and then a fracture pan, which is that tiny little triangular one. Okay, so hopefully you'll have an opportunity to put a patient on a bedpan this week. The graduate cylinder is that triangular shaped cylinder that we use to empty the Foley, or if there's any drains or tubes, we use that to empty, usually at the end of the shift or however designated for that patient. And then it's got the milliliters on the side, so again, that we can document output. Okay, specimen cup was pictured previously. We'll use that to collect a urinalysis. They usually, you guys who work in the field, do you have different ones for urine culture? Yeah, it's a special one for urine culture. A Foley bag is pictured right, the first picture, A, is a Foley bag that has a built-in, that plastic box is built into it. Some of them have those too that you can see like hourly output. It's more accurate, I guess, but then it just dumps into the bag. So you can, it'll collect in that little plastic box, and then you'll dump it out into the back side of it, into the bag, and then empty it the regular way. Or over there in the middle, B is one that's probably more familiar to you, is a Foley catheter drainage bag. So that would be for a bedbound patient, a hospital patient. This picture here in B is a leg bag. So a patient at home who's maybe got some chronic prostate issues and always has to have a catheter and can't be without one. Maybe they'll hook it up to the bag at bedtime and then unhook the catheter from that tubing at bedtime and hook it over to a leg bag in the morning when they get up, so they can walk around and they don't have this big bag trailing behind them. Bedside commode, you guys should all be familiar with that. The catheters themselves, there's 3 different types of catheters. There are intermittent, Foley, and suprapubic. Well, those are the 3 types of catheters that you'll see are a single lumen, a double lumen, and a triple lumen. Okay, so a single lumen is going to be for intermittent cathing. So maybe a patient was in a motor vehicle accident and they're paralyzed and they can't control their bladder, so they have to cath themselves so many times a day. So they would just use a straight catheter. There's no port for a balloon or for anything like that because it just goes in, it drains the urine out, and then we dispose of it. We take it out and get rid of it. Okay, so that would be intermittent catheterization. A Foley catheter is gonna be your double lumen, the one in the middle. Okay, and the second lumen is to inflate that balloon, to keep it in the bladder, right? So we insert the catheter, the main tube drains urine, the second tube is connected to that inflated balloon up there, so we'll take, it's usually 10 cc's of saline or water, and we inject that balloon, it's in the bladder, and then it can't get through into the urethra. It just sits there in the bladder, it can't be pulled out. Some people can pull them out.
Oh.
But have you ever seen those memes with the old lady just like pulled her catheter out and she's just bleeding all over? Some people can pull them out, you shouldn't pull them out. So that it would be a double lumen for a Foley catheter. A triple lumen catheter, can you guess what that would be for? Anybody? No. Would be for irrigation. Okay, so we need the single lumen for drainage, the second lumen for that balloon to inflate that and keep that in the bladder. And then the third lumen is open to connect to saline tubing, and they'll continuously be flushing the bladder. So if they've had bladder surgery and they're expecting to have some bleeding and some drainage for a while, they'll hook them up to a 3-way with bladder irrigation, so it's continuously irrigating and then draining out into the Foley bag. Okay, so we've got single, double, triple lumen, intermittent, Foley we talked about, and then suprapubic is just the location. So if they have, for whatever reason, have to bypass the urethra, they can have a catheter right in the suprapubic area directly into the bladder. And it just drains right there, drains out there. Okay, so this goes along with catheter insertion, which is your next skill check off, and it is a sterile check off, remember? So you'll definitely, there's a picture of sterile gloves here. You guys have some in your kit. Have you practiced with them yet? You haven't had to. Okay, so you can practice, watch the videos, and practice how to open that and get your hands in there. Next, when we come back next, I will demo a catheter insertion. We'll have time next week, not next week, but the week after that, when we come back from spring break, I'll try to bring like a mannequin or a torso in and a Foley kit and show you guys how to do that. There's lots of steps, you really do have to practice it, but really once you get it, just like anything else, it's no more difficult than any other skill that you would have to do. So we'll go through that. Remember from that very first week when we talked about clean versus sterile, and only sterile items are used within a sterile field. Okay, so only sterile can touch sterile. Tables are only sterile at waist level, right, not below. Persons who are sterile touch only sterile items or areas. Okay, so if I've got my sterile gloves on, now whatever I'm working with should be laid out in front of me, and I'm not gonna turn, I'm not gonna let that not be in my view, and I'm not gonna go like this, right, because now I've contaminated my sterile gloves. I'm not gonna go like this, because then I've contaminated, and if I touch the patient, now I've contaminated. If I've touched the bed, now I've contaminated. Anything that's not sterile. So if I were to, maybe somebody was helping me and they needed a pair of regular gloves, and the gloves are right next to me, and I took my sterile hands and I got her some gloves, now I'm contaminated. Okay, so anything you touch that is not sterile, you're contaminating. The edges are considered contaminated, that 1-inch border. We want to make that field as close as possible to the time of use, so I wouldn't, if I was going to insert a catheter, I wouldn't go in and open everything up and then leave and then come back in. You would never do that. Even though we can touch sterile things, we do want to keep contact to a minimum. Destruction of integrity of microbial barriers results in contamination. So that is speaking about like fluids. So if you have because we used to talk about this for dressing changes. If we needed to use some gauze with saline, we would set up our sterile field and then open gauze and then squirt saline on it so that it's ready to go and use it. But if the field that you're using is not waterproof and that water leaks to the bottom of it, supposedly bacteria from underneath it can be absorbed up through the water into your site. So make sure that your field is waterproof if you're gonna get it contaminated, if you're gonna get it wet. Okay, so usually though, if you get a sterile field wet, it contaminates it. Okay, catheter insertion, we use sterile gloves and a sterile catheter kit. You guys all have those, right? At home, if you're curious, you can open them up, check them out. Just make sure you put it back how you took it apart. So maybe take pictures of it as you go. And it's always harder to put it back together once you've undone it. So, but as long as you take pictures and keep track, you can get it back. The videos you guys probably haven't watched yet because they weren't due this week, right? They'll be due when you guys come back. But, so just like she was saying for her cystoscope, she lubricated that right before she inserted it so that it goes in easier. We have to do that with a catheter as well when we insert it. And we just open that lubricant, dump it on our field, and dip the end of the catheter into it so that the catheter is moistened, and then we go ahead and insert it. In your video for the male, they take a syringe of lubricant and insert it into the male urethra. And I don't know how that came about, but we don't do that. So when you watch that video, you'll just be like, oh. Yeah, so I don't know why they do that.
Wow.
Okay, assessment for the urinary system. Okay, like anything else, we do a comprehensive nursing assessment. We look at vitals, we do a head-to-toe assessment, including intake and output. We can look at lab work. If there's a specific problem with a peri area, we would assess that. If a patient is having trouble with retention, we can use a bedside bladder scanner, which some of you are familiar with, right? Some of you guys use those, yes? Yes. Okay, so it's just a handheld ultrasound. Every unit usually has one, and if we get the chance to, we can have some staff show us how to use it, or if any of your peers know how to use it. I used to know how to use it, but I'm not sure that I might be able to figure it out, but you just turn it on and it kind of follows you through the steps. So you would use jelly, like ultrasound jelly, put it over their bladder and then hold that, and it will visualize the fluid in the bladder, and it'll give you an estimate of how many milliliters are in the bladder. So if a patient urinates, and then you do that and they still have like 300 milliliters, well, there's something wrong. They're not able to empty their bladder. Urinary characteristics, so know what is normal in a UA and what is abnormal. Okay, so it should be clear, yellow, not too dilute, not too concentrated, and the things that should be in urine and what should not be in urine. Urinalysis, really they just have to be clean. They usually come with those hand sandy wipe things that they can use to clean, but it doesn't have to be sterile, so they can pee in the cup or they can pee in a collection container, and then you can pour it into the cup for your sample. A midstream though, which you guys will see when you guys come back, is just like it sounds. It's a midstream, so the patient has to have some cognition and some coordination. They would have to do hygiene, and then they would start their urine flow, and then after it starts, they would stop. So you squeeze those muscles, which are Kegel exercises, right? Strengthening the pelvic muscles. So squeeze those muscles to stop it. Then they would hold that cup in place and continue peeing, and then they would stop, remove it, and then finish peeing. So it's a midstream specimen. Sterile specimen is going to really be obtained by catheterization only, is really the only way to get a sterile specimen. Okay, so if they already, if they don't have a catheter, we use a little cath kit. There's like a little tube, and then a collecting tube, and then a little straw-like thing comes out the top of it, and it's just a one-time, you insert it in the urethra after doing all the proper cleansing, and then it fills up the tube, and then you remove it, throw the insertion tube away and then send that collection tube to lab. Or if they do have a Foley catheter, you can see here on this picture, so the second picture where the gloved hand is, you can see like the tannish yellow of the catheter itself, right? So that's the part that's inserted into the urethra. And then about where their hand is, some of these don't disconnect, but most of them and all the old ones will disconnect right there from the drainage bag to the catheter. Okay, you would never want to disconnect that because that disrupts the integrity of the system. But there's a little port right there, and you'll see this in your kits, that we can hook a Waterlock up to, or a syringe without anything, without a needle or anything onto it. We clean that site, and that syringe will just twist right on to that port. And if there's urine there, we can collect that. If there's not, and there's usually not, we would go in, make sure the tube is cleared. Below that site, we would kink that tubing up with a rubber band, close it off, leave them for 20 minutes or so, come back, and then there's gonna be some fresh urine right there. So we can access the site, get our sterile specimen, and then send it to lab, and then unkink it, of course, because you don't want their bladder to explode. 24-hour testing, if they have kidney disease, they'll have a 24-hour urine collection, and we'll say we just got orders and our patient's gonna start this collection at 9 a.m. Okay, so I go in at 9 a.m. and I take them to the bathroom and they urinate and I flush that. Okay, I don't save that, but that is my start time, it's 9 a.m. So then anything else after that, when they urinate, they should pee in the hat, right, that cylinder that you put in the toilet, and then we dump that into whatever collection device lab has given us. And then typically we have to keep it on ice. So there'll be a basin with ice in the bathroom that jug sits in. Okay, and then at 9 o'clock, it's the next morning, it's over, we send that to lab. Okay, so a lot of instruction for the patient, a lot of following up and monitoring, keeping that ice refilled so it doesn't go bad. That's typical 24-hour testing. And then point of care testing is like the test strips, the pH strips. If you've ever been pregnant, you go to the doctor and every time you urinate and they want you to dip and make sure there's no glucose or protein in the urine. So that's point of care testing. You might see that. Does anybody do that where they work, point of care urine testing? Probably not so much because we just send it to lab. Hi, Joe. Okay. All right, diagnoses. Work on some of these. Okay, so if we've identified urinary retention, let's come back to that one. Let's go down to, let's start at the bottom. Okay, impaired skin integrity. Okay, if we're thinking about urinary problems, that would most likely be related to incontinence, right? Okay, so impaired skin integrity related to incontinence, and then that would be as evidenced by what?
Irritated skin.
Okay, irritated skin or red, excoriated skin in the peri area, it would be. Okay. Risk for urge incontinence could be related to what? Okay, urge incontinence is I gotta go and I gotta go now, and if I can't get to where I have to go, I'm gonna be incontinent. Immobility for sure. Huh?
Stress.
Stress, maybe.
Parkinson's?
What?
Parkinson's? maybe?
Okay, maybe Parkinson's. Medications, specifically diuretics. Okay, so don't give your patient Lasix and then leave them alone because you know that they're gonna have to get up to go to the bathroom. Maybe stress, urinary incontinence related to weak pelvic floor muscles as evidenced by
Postpartum.
dribbles when they sneeze or whatever it may be. Okay, impaired urinary elimination is kind of generic, can apply to lots of things. Maybe related to anxiety, as evidenced by patient states, I can't pee in the hospital, I'm too nervous. Okay, toileting self-care deficit related to, could be lots of things, right? They're physical immobility, maybe cognition, maybe shortness of breath. Okay, as evidenced by they need help. They can't take care of their toiletries independently, and they need assistance. Urinary infection related to what could cause a urinary infection?
Bedbound? Bedbound?
Maybe if they're bedbound, especially if they're incontinent. Maybe poor sanitation is usually what it boils down to. As evidenced by the urine culture is positive for E. coli. Whatever it may be. Okay, we talked about E. coli is common in the stool, shouldn't be in the urinary system, so if they are wiping back to front instead of front to back, you'll see E. coli in their urine culture. Okay, and then urinary retention could be related to what? There's a couple, 2-3 things that I know we talked about that can cause urinary retention.
Increased salt.
What does urinary retention mean?
Holding.
Okay, not able to excrete it. What could cause that?
Anxiety.
Okay, anxiety.
Something blocking the ureters.
Okay, I'm thinking of physical things.
Dehydration.
Somebody said it. Kidney stones. Okay, kidney stones or tumor are the most common ones. Okay, as evidenced by what? Unable to void, not peeing. Okay, so whatever the problem is, we want to plan for that to be resolved. We want their INO to be equal, we want their electrolyte levels to be within normal limits. Okay, we don't want their skin to break down. We want them to be able to take care of themselves hygiene-wise as best as they can. Okay, our interventions are gonna focus on promoting and maintaining normal urinary patterns. Okay, so just offering the toileting them will make a big improvement. Toileting schedules will help prevent incontinence as well. Preventing problems associated with bladder catheterization. So what's the main problem associated with catheterization?
Infection.
Infection. And so how can we prevent that?
Sterile technique.
Sterile technique, putting it in. Sure. Make sure it's not kinked.
We'll do like catheter care every shift.
Catheter care every shift is a big one. Perfect. Maybe make sure they have that stat lock on it to keep it in place so it doesn't snag and pull, because that's going to cause trauma, which can make them more prone to infection. And then any diversions, which there's a video in here with urinary diversions that you can see, but any man-made drainage or diversion would have to care for that as well with aseptic technique. Okay, the most common problems that we see with urinary, one is going to be UTI, okay, urinary tract infection. And what are some of the things that we can do to prevent or help with urinary tract infection? Fluid, okay? Make sure they drink plenty of water, dilute that urine out so it's not so acidic and irritating. Okay, what else?
Go to the bathroom frequently.
Okay, make sure to go to the bathroom and void at least every 2-3 hours.
Medication.
What about medications? If they have an infection, give them their antibiotics, okay?
Hygiene.
Cleanliness.
Cleanliness, hairy care, okay? And then showers are better than baths, especially for women, because we do have that short urethra. It's easy for bacteria to flow in the wrong way, so showers are always better. Voiding, educating the patient to void after any sexual intercourse, drinking water before intercourse and after, and then no powders or irritants or douches or anything like that. They upset the normal flora, so that can increase risk for infection. Okay, what about incontinence? That's another one. What can we do for incontinence?
Make sure to change the incontinence pad regularly.
Okay, make sure that we change that pad, make sure they're clean and dry, so that's not just sitting on their skin. What else?
Limit their, fluid intake.
Is that a good idea? Can we dehydrate them?
For our convenience. I'm busy, no water today.
Limit alcohol and caffeine.
Okay. Access to the bathroom. Okay, so however they use the bathroom, if it's bedside commode, make sure it's there for them. If they need assistance with it, make sure we're available for them. If they can get up to the bathroom, as long as there's a clear path, make sure there's a clear path. If they can do it as long as they have their walker, make sure they have their walker. Okay, the bladder training program. So we know as humans, we have to excrete waste frequently, so getting in there ahead of time and getting them to the bathroom can help prevent incontinence. And then nocturia, having to get up to use the bathroom at night. Sometimes that's just something that happens. Maybe we can look at their scheduling of medications. If they are on a diuretic, make sure it's in the morning and early afternoon, not in the evening, because then for sure they're gonna be getting up to urinate. We don't wanna limit their fluids, but we can limit fluids at bedtime. So make sure they get all their fluids in throughout the day, not at night, so they don't have to go as much. And then if we just can't help it and they do have to get up, make sure there's a night light, a clear path. They have loose clothing that's easy to get on and off, so it's not too much of a burden when they do get up to go to the bathroom. Okay, stents, you can watch this video. It would be specifically like for a stone or for a stricture. For some reason, the kidneys can't drain into the bladder, so they can put a stent in there to help with drainage. This is a urinary diversion, so I think this patient had bladder cancer, so they had to remove the bladder. And then in this video, they show you how they use part of the bowel to connect the ureters and then create a stoma through the abdomen for urinary excretion. Here's a picture of bladder irrigation. So what kind of catheter is this gonna be?
Suprapubic.
A what?
Suprapubic.
No,
Three,
a triple lumen. So remember, there's single lumen, double lumen, triple lumen. A single is for intermittent, I'm just cathing and then throwing it away. Double lumen is gonna be my normal, my Foley catheter. One for drainage, one for that balloon to keep it in place. Triple lumen is gonna be one for the balloon to keep it in place, one for urinary drainage, and one for that continuous irrigation of that saline that's going into the bladder and draining out. Okay, dialysis. Remember, the kidneys excrete and filter waste. If they're busted and broken and can't do it, we can't let those toxins and waste build up in our body. So we have to eventually have dialysis. If they have a temporary line, it might look like that picture up there, that double lumen. It's a central line. Only the dialysis techs touch this. Nursing does not touch it. We don't do anything with it. The dialysis nurse takes care of that. Okay, this picture here is kind of hard to see, but it would be of a fistula. So it's a surgery that the patient has that they connect arteries and veins, and then they'll take two needles, which you can kind of see in the bottom picture, and put those into the fistula and then pull out all the blood and filter it and put it back in. Okay, so each time they go, which is typically 2-3 times a week, they would have to have that accessed with the needles. You guys use numbing spray or numbing cream? Nothing? Some do. Does it help them? Some of them don't feel it though.
They feel it, they just get
They're
used
just
to it.
like whatever. Okay. Right. And it usually takes several hours.
It's usually 4, 3 and 4.
Okay. So you might see if you have a patient that you're taking care of that needs dialysis, maybe you can follow them over to the dialysis room and watch them get hooked up and see how all of that works. Okay, and then evaluation, okay, are the things that we want to be normal, stay normal. Their INO, their electrolyte balance, okay, is their hygiene okay? Do they have everything they need to take care of their elimination? Okay, if they have any specific diversions or tubing, caring for those, preventing infection. Okay, and we did our review at the beginning. So I'll be looking at those and putting in the points today, later today. good
Alrighty,
break, you
let me know.
guys. I'll see some of you tomorrow. No. Yes. Yep. On the floor, ready to go by 6.
So if we get there by like 5:45, we're good.
Remember my point for the thank you card. Right there.